Hi, and welcome to a Safe Airway Society podcast, where we aim to advance airway management through collaboration. My name is Matt Humar. I'm an intensive care paramedic and a SAS board member. And today we have the distinct pleasure of talking to Dr. John Glasheen, who is a emergency and retrieval registrar with Lifelike Retrieval Medicine in Brisbane, Queensland. And we're going to talk to John today about a paper that was published in the Emergency Medical Journal in February of this year. And that paper is titled Successful Endotracheal Intubation Following a Failed First Attempt During Aeromedical Retrieval. So without further ado, we have John on the Zoom. John, welcome, and thank you so much for joining us. Really appreciate it.
Thanks, Matt, and thanks for having me. First of all, congratulations on getting the Safe Airway Society off the ground. I think it's a fantastic initiative. I think getting all of the different professional bodies to come together in one professional body is a fantastic step into the future and into common sense. So well done.
John, thank you so much, mate. And I should mention, thank you for your SAS membership, which is greatly appreciated. It's a great endeavour, and many good things to come in the future. So watch this space. So John, your paper, it probably was published around the time when COVID was starting to take off, I would imagine. So, and on that point, it's sort of nice to talk to someone about a non-COVID-19 related issue, as necessary as it has been over the last few months. So we want to talk about your paper that you were published in February, I believe it was.
Yeah.
Yep. Beautiful. What? Give us a brief synopsis of the paper without going into too much detail, because we'll break it down as the podcast progresses. But just a general overview of what you looked at.
Sure. Well, we looked at the Lifelike Airway Registry, which was set up in 2014, and that migrated to an electronic platform in 2015. And we looked at 762 intubations over that sort of 41-month time period. And we broke it down into those intubations that weren't successful at the first attempt, and then looked at what changed between an operator's first attempt and a successful second attempt or a successful third attempt, or in fact a failed intubation, of which there were 4. And then we just identified what the people did between that failed first or second attempt and a successful subsequent attempt, because the Difficult Airway Society in their guidelines in 2015 suggested that if there was a failed intubation attempt, then there should be a change. So rather than just doing the same old thing again and hoping for a different result, then you should change something. But they didn't provide much guidance on what exactly should change. And I think that's because that guidance doesn't really exist at this point in time. So our paper was designed to find out what our clinicians did, not necessarily to suggest that is the right thing to do, but to find out what they actually did.
Very good. And this is something that I suppose is talked about a lot, between the first, second, third attempt that you change something. But I don't think I've ever seen a paper that actually dissects it like yours has, John. Was that the motivation for this research, for filling a gap within the evidence base?
Yeah, that's pretty much it. I mean, I had a failed intubation, not a failed first attempt on a case myself, and then a few other cases came through our audit process around the same time, and it just got me thinking. What should I have done differently? What should I have changed between the first and second attempt? And in fact, should I have identified this prior to the first attempt, and would that have made it a first attempt success? And I was also reading about the topic, and there's a whole heap of stuff about first attempt success or first pass success, which I actually think are two different things. We might come back to that in a little bit. We know that the complication rate goes up the more intubation attempts you have, and a lot of services will use the first attempt success rate as a marker of their quality, so as a key performance indicator. But there was a paper from Walker in Pre-Hospital Emergency Care in 2018, which suggested that perhaps that's not the best approach, that they were finding some physiological deterioration between first and second attempts, but actually what they found is that the highest number of altered physiology was during a successful first attempt. And they postulated that perhaps people were focusing on getting the tube in the first time to the detriment of allowing the physiology to deteriorate. And perhaps that focus on a successful first attempt should migrate to a focus on minding the physiology or managing the physiology, as opposed to simply getting the tube in first time.
Yeah, very interesting. And that's a point that you make in this paper that was a bit of a light bulb moment for me, John. Like that first pass success rate that we all aim for, and without deterioration, obviously. But at what expense is that happening? And that's a big question mark at this point. So no, that is great. And just for the listeners, moving back to what sort of service do you work in? Just tell me a little bit about Lifelike Retrieval, bases, your crew makeup, what your general workload is like.
Yeah, Lifelike operates predominantly in Queensland, and it's Lifelike's both an aviation provider and a medical provider. So Lifelike Rescue provides the aircraft, and Lifelike Retrieval Medicine provides clinical staff. So Lifelike has 6 helicopter bases where Lifelike actually provides the helicopter, and Lifelike doctors also work on Queensland Government Air helicopters in Brisbane, Townsville and Cairns, on Capricorn Rescue helicopters in Rockhampton, and on Central Queensland Rescue helicopters in Mackay, as well as on RFDS aircraft.
Right.
The RFDS system. On some of the Lifelike aircraft, we work very closely with Queensland Ambulance Service critical care flight paramedics, and on some of the Lifelike aircraft, we work with Lifelike nurses. So your crewing composition can change from day to day. Your aircraft can change from day to day, from helicopter to RFDS King Airs to Lifelike jets. So you never quite know. Well, you do know because it's on the roster, but you could have any sort of crew mix or any platform on any given day. So it's quite interesting. Lifelike does about 6,000 retrievals a year.
Yep.
About 70% of those total number of retrievals are intra-hospital transfers, and about 30% are primary. But obviously, all of the jets and the fixed wing are essentially 100% retrieval. So the primary and IHT mix in the helicopters varies from base to base, but typically it's about 50 to 60% primary.
Okay, fantastic. What was we're going to go to next? So we've looked at so far a bit of a summary of your paper. We know what the context of where you work, John. Can you just elaborate a little bit more on your Airway Registry that you have and use within Lifelike? So I believe you use the Australian and New Zealand Emergency Registry as a bit of a template, and you've added a few retrieval-specific categories into there. So after a case, what happens?
Yeah, so after a case, we enter. So during a case, we record all the patient details on a traditional paper form. And after the case, all those details are transcribed essentially into an electronic registry, which is the platform we use is Air Maestro. And if you tick a box to say that you've intubated a patient during your mission, then another page pops up, which is the Airway Registry. And as you said, Matt, the Airway Registry is predominantly based on the Australian-New Zealand ED Airway Registry, with a few pre-hospital fields added. For example, the location of the intubation of the patient, be it in the back of an ambulance or on the ground, and so on. But predominantly, it's the same format as the Australian-New Zealand ED Airway Registry.
Yep, fantastic.
That whole system became much easier to use in 2015 when we migrated from a totally paper system to an electronic registry. It just makes it so much easier to search reliably and robustly.
Nice, and that's a nice segue into the next question. So that's sort of where your data collection started when it moved to the electronic system from 2015, and over that a 41-month period up until 2018, you looked at intubations, and in particular the intubations where there was more than one attempt. Is that right, John?
Yeah, that's correct. So the 41-month study period is a bit of an unusual one. I've not seen 41 months before, but it was simply for pragmatic reasons. That was from the date the electronic registry started until the date that we captured the data, essentially.
Yeah.
And over that time period, there were 762 intubations. The Lifelike teams were successful in the first attempt in about 90%, so 89.8% first attempt success rate. And I'd just like to clarify this point, Matt, that the Lifelike definition of an intubation attempt is the same as the Difficult Airways Society definition, so placing the laryngoscope in the mouth with the intention to intubate. I think that the danger of using a term like the first pass is that people can interpret a pass as trying to pass the tube. So, for example, if you're outside on a bright day, you put the laryngoscope in and you can see nothing because of glare, and you don't even try to put a tube in, then that is still an attempt.
Yep.
But some people have an interpretation that because they didn't try to physically pass the tube, then it doesn't count as a pass. And that's why we deliberately use the expression first attempt. Some services will use first look as an equivalent, but I think avoiding the expression first pass is a good way forward in terms of standardizing our data collection.
Yeah, couldn't agree more. Yeah, that's a great point to make, John. Thank you. So you were looking at not only success rates, but obviously the things that change between your attempts. So just to break down what you found, mate, so what again was your first pass success, your overall success, and then just give us a bit of an outline of what you found that changed between first, second, and third attempts.
Yeah, sure, Matt. So the first attempt success rate was 89.8%, with an overall successful intubation rate of 99.5%. So we had 4 cases that we couldn't intubate. 2 of those required surgical airways, which in our service is a finger bougie tube technique. And one of those cases was intubated through a pre-existing tracheostomy, and one of the cases was transported with a rescue LMA in situ and was successfully ventilated with that LMA. In terms of first attempt success rate, there was no difference between medical and trauma cases. So there's been a traditional thought that, perhaps trauma airways are more difficult. That wasn't borne out by our data. There was no difference between success rates in primary missions and intra-hospital missions. And there was no difference between video laryngoscopy and direct laryngoscopy. Okay. I think the literature about video and direct laryngoscopy can be a little bit confusing. There are conflicting results. And my personal take on that is that the clinicians who intubate in services like Lifelike, to quote Mike Abernethy from the US, this is not an entry-level position. And the majority of, in fact, all the clinicians who perform it in our environment are experienced clinicians. I think there's certainly a place for video laryngoscopy for inexperienced practitioners, and they certainly have their place for truly anatomically difficult airways. But the number of those is quite small. So I think in a service like ours, to show a difference with video laryngoscopy for those true anatomically difficult airways would need enormous numbers, which we just don't have. And I think that accounts for the fact that we showed no difference between direct and video.
Yeah. I noticed that, John. They're all around the 9% mark for each of those categories that you just mentioned, I believe. So it's a great finding, I find, and I think it's a very valid point to make about the experience level of the intubator and how that affects trauma medical, direct, indirect laryngoscopy. And I think inter-hospital transfer as well as primary had a very similar rate of success as well. The other point that we need to talk to just now, John, is the changes that were made between the first, second and third attempt. And then I think I want to just rewind a little bit and discuss your standard operating procedure and how you approach intubation in the field. Like, who does it? What is your primary laryngoscope device? What is your intubating aid if used on a standard approach, etc. So first with your primary findings of the changes between first, second, third attempts.
Sorry, Matt, I just lost you there for a second.
No worries, mate. So the primary findings that you found about the differences or the technique operator differences made between first, second, and the third attempts that you found.
Yeah, sure. Okay, sorry. So in 88% of failed first attempts, or failed attempts rather, a change was made. In 36%, one change was made, and then 52% more than one change was made between a failed attempt and a successful subsequent attempt. And interestingly, in 12% of cases, no change was made between a failed attempt and a successful attempt. We might come back and revisit that later on. In terms of the number of changes, the majority of cases were intubated after a second attempt. So, like I said earlier, 89.8% were successfully intubated at the first attempt, and a further 8.5% were intubated successfully at a second attempt. So, the vast majority of cases were intubated at 2 attempts. Between a failed first and a successful second attempt, the changes were predominantly the intubating aid. And interestingly, so our SOP states that we will use a video device, which is the McGrath video laryngoscope, but use that as a direct laryngoscopy technique with the bougie for the first attempt. So we use a bougie for all attempts just to maintain everyone's familiarity with it. There is sometimes a small time penalty associated with the bougie use, but it does increase your first attempt success rate. And we sort of believe that, similar to other services, that if you use the bougie for every attempt, then you're not just pulling it out of the toy box when you've got a difficult one, and therefore everyone is more familiar with its use and more slick with the procedure. But interestingly, between a fail first and a successful second attempt, there were 21 changes in the intubating aid, but an equal sort of spread of change from bougie to stylet or from stylet to bougie. And in 6 cases, there was a change from no aid to using a bougie. And I guess that those cases where no aid was used was a deviation from our SOP. But clinicians are certainly entitled to deviate from the guideline. It is just a guideline, and sometimes you need to do what you need to do in a given situation.
And I really like that point you just made there about the intubation aid, and how the bougie, especially over the last 5 years, has become more routine than just something that's used when difficulty is encountered. But vice versa is also true, where when there's failed or unsuccessful intubation with a bougie, then the next logical point is to move to something different, and that is a stylet. So it's not absolute either way, is it, John?
Yeah, that's right. And I think our data system didn't unfortunately capture this terribly well, but when we use our hyperangulated blade, so the X blade for the McGrath, then you do need to use a stylet to shape the tube to go in the same direction as the blade. And I wonder if some of those changes from bougie to stylet were to facilitate the use of the X blade.
Yeah, very good point. Very good point. So from the second to the third attempt, what were the numbers again? So you've captured most patients have been successful with first to second, but there was a few that needed third, and there were a few changes made there as well.
65 second attempts were successful. And then on the third attempt, there were 9 successful intubations on the third attempt. The majority of changes between the second and third attempts took place in the operator, and there was about an even mix of change between physician to paramedic and paramedic to physician. And in fact, in one of the successful third cases, there was a switch between first and second from doctor to paramedic, and a switch between second and third from paramedic back to the same doctor who was successful on the third attempt. So I think there's certainly a safety element in having 2 clinicians who can intubate on a crew, but that also runs the risk of diluting the experience. Mm-hmm. We don't do a huge amount of intubations. Somewhere just a little bit more than 1 in 20 of the Lifelike missions will end up in an intubation. And if you essentially double the number of people who are intubating, then you half the experience of all of your crews.
Yeah. Good point.
There's no answer to this. I don't propose to have an answer. I think there's certainly a safety benefit to having 2 clinicians who can perform the intubation. But like I said, there is an experiential element or an experiential penalty to that safety element as well.
Yeah, and you make a very good point in your paper, John, in your discussion, that a change of operator is a very reasonable approach when there hasn't been success for your first, for instance. But in the same breath, that first operator has done a little bit of homework into the airway, that experienced difficulty, and then on that second attempt, they may be in a better position to be more successful when they go back in. So there is merit either way, isn't there? I think.
Yeah, there is. I don't think there is. Certainly, this paper doesn't propose to have an answer to that huge question. I'm not sure if there is an answer to that question. Mm-hmm. And I've done a bit of searching. I've actually spoken to a psychologist about this. So in about 12% of cases, there was no change between a failed attempt and a successful second or third attempt. I think some of those cases were because people didn't probably wait long enough for the rock to have full effect. We use rock as our primary paralyzing agent, so perhaps they didn't wait long enough for the rock to take full effect before their first attempt. I think that accounts for some of it, but I do think there's also a more complex psychomotor thing that you've had a look, you can't quite identify what you need to do different, but you just know.
Mm.
The closest thing I can equate that to in other sort of worlds is if you've got a footballer who kicks for goal, they'll want to kick in the stadium that they're going to play in. Now, it's the same ball, grass is grass, and a goalpost is the goalpost, but yet they need and want to practice in the actual stadium they're going to play their cup final or whatever it is in. And I wonder if it's the same for us in our world. An airway is an airway, a laryngoscope is a laryngoscope, but you stick it into that airway, and is it just a bit different? And do you need to see that particular airway? And if you've seen it once, is it easier the second time? Yeah. If anyone clever out there has the answer to that question, I would love to know it.
It's that tacit knowledge that just can't be put into words sometimes.
Yeah, exactly right.
Great mystery of the unconsciousness. I'm just wary of time, John, so we'll move on to the last few questions. So we've spoken about the aim of your study, what you did, your results. What, from your perspective, were some of the key findings and takeaways, like the big messages that you've that Lifelike have taken from your paper, for instance?
Sure. I guess the first thing is that 90% first attempt success rate is reasonable. There's certainly room for improvement with that, but it seems that our crews are reasonably well trained, both in terms of their training sort of level when they come into the service, the training they get at the start of their term, and the ongoing training throughout the term seems to be reasonably effective. The equipment we have appears to be fit for purpose, and the systems that we've got in place, both in terms of facilitating the high performance of our teams, and also the governance structures afterwards seem to be effective in achieving their objectives. Having said that, there is some room for improvement. I think reminding people to allow full effect of the rock to take place before the first attempt, reminding people to use the bougie for every attempt, and also just increasing that sort of awareness that you need to be able to identify what did go wrong on your first attempt, and to remedy that, not just to change something for the change of changing something, but to identify what change is actually going to be effective before your next attempt. I think that's the trick, but also very hard to train.
Yeah, absolutely. And I love the way that you framed this in your paper, John, how you've said 1 out of 10 intubation attempts failed on the first go, rather than saying 9 out of 10 was successful. It really shows a culture within your organisation where you're doing very well, 90%, and then 99.5% overall success is on parallel with some of the best numbers I've seen. But you're still looking for ways to make it a bit better, safer for patients, and that's very admirable. Right? So well done on that front.
Gains to be made. I think that the gains from this point on are quite difficult. It's easy to implement an SOP, a training program, add the bougie, do nasal oxygenation, apneic oxygenation rather, during your intubation attempts. But once you've got all of those identified things in process, then the marginal gains from that point on are trickier.
Yeah, no doubt. A few more questions. Did anything surprise you from your results? Was anything unexpected, or was it sort of the way you thought the study was going to unfold? Did?
Yeah, pretty much. I've been sort of monitoring the data as it was coming in, and doing sort of weekly audit on that just around the time we started the project. So I guess the results to me weren't terribly surprising, because I'd seen the trends up until that point. But it's pleasing to see that the standards throughout a big organization, so that the first attempt success throughout all of our bases is essentially the same, and that's sort of, I guess, pleasing from a systemic point of view.
Yep.
And all of our kits are set up the same, the SOP is the same throughout the state. So if you go from base to base, you can expect to work in the same way with different people, regardless of where you are. And I think that certainly increases the safety margin within a big and complex system like ours.
No doubt. Yeah, but the expectation of the knowledge of the environment, and that's what changes within pre-hospital. But the kit is something that you need to be standardised, and that I think that cognitive load is lessened dramatically when you open a bag and you know exactly where everything is and where it's going to be. It's a very important factor. What has happened with this information, if anything, John? And then has this informed practice? Has this been disseminated to everyone involved in intubation within Lifelike, and training programs have been made? So has there been any change since this paper has been published?
We produce an airway sort of audit bulletin or clinical governance bulletin, which includes an airway audit every month. And so this information is being disseminated throughout all of our clinicians via that airway audit. And I think it's really important that everyone is sort of on the same page. And, this bulletin goes to our QAS colleagues and our nurse colleagues, as well as the doctor cohort, obviously, to ensure that everyone is sort of up to speed on where we are. It hasn't changed the SOP so far. Our SOP is probably due for review, I think, in July of this year. So perhaps some of the findings will be incorporated, but I don't think it identifies a big change that we should make, aside from emphasizing the fact to people that the SOP is there for a reason, and stuff like use the bougie first time, allow time for the rock, and then identify the change that needs to be made before your second attempt.
Yeah, wonderful. That is all the questions I have for you, John. Before we go, is there anything else that you want to share from the paper or other? Any other last final thoughts, so to speak?
I think the thing that I would take from all this is that 90% or 90% is pretty good, but there's a lot of work that goes into making that 90%. And like I mentioned earlier, the training process, but also the ongoing training process. That we do daily drills with your flight nurse, your paramedic, sort of on every shift. I think that's important in lower volume systems. If you're actually intubating every second or third shift, then you possibly don't need to do as much simulation. But if you only intubate one every sort of 18 or 20 shifts, then you certainly do need to keep your skills up, certainly from the non-technical perspective, by doing simulations and realistic simulations where you do it in the aircraft, on the ground, not just on a table in the office, if you like. And sort of that in situ simulation is really useful to involve the whole process, not just the intubation, but often having our flight crew involved in the process to give them an understanding of how things flow and how things work is really useful to get them involved in our daily sims as well.
Yeah, wonderful. And such an important point, John. Success doesn't just happen. Absolutely, there's training and practice that goes behind it, and lots of it, and continuous spaced repetition training is something that is so important to have numbers like you have represented in your paper. So John, thank you so much for joining us today. Really do appreciate you taking the time to discuss your paper. And I'd like to once again congratulate you on such a profound research that not only makes airway management better for Lifelike, but definitely extrapolates to other pre-hospital and in-hospital services, both in Australia and around the world. So well done.
Thanks very much. Thanks for the interest in the paper. It's nice to get it out there a little bit.
Fantastic. So that's it for the podcast. If there are any questions from the listeners, please do feel free to email them out to admin@safeairwaysociety.org. You can find that email address on our website, or you could locate us on Twitter and Facebook under our handle Safe Airway. Lastly, a big thank you to all the SAS members. This is not possible without you, and we very much appreciate your membership. Stay tuned. There's more to come in the not so distant future. Thank you very much.